This topic is about psychopharmacology. This is one of the hot topic in psychiatric nursing. And most of the board questions, not only from the local but also from the international arena, are taken from this subject. The examiner will test your skills in administering medication with their respective safety issues and, of course, the nursing consideration or responsibilities. Definitely, there will be a lot of memory work here that you have to invest in. But as much as possible, we will try to give it our best shot to simplify and still enjoy this topic. Welcome to psychopharmacology. The psychotropic drugs and their categories. These drugs are broad categories of drugs that treat many different conditions or a variety of psychiatric conditions that you're seeing right in your screen. It acts by adjusting the levels of the brain chemicals, or what we call the neurotransmitters, which we have discussed in the previous video. There are 5 major categories. One is the antipsychotic. Second is the antidepressant. The third is the mood stabilizer. The fourth is the stimulant. And finally, we have what we call the anti-anxiety or the anxiolytics. In our attempt to simplify or systematically digest all of the important concepts that we will be dealing with, at this point, we will use a strategy like that of the nursing process. But this one will focus on our systematic and scientific approach of pharmacology. And this is what we call the drug study. Now, to deal with the drugs, we will first try to know the drug name and classification. What kind of a drug are we dealing with? Second, we will know what is the indication and the contraindication. When do we use these drugs and when do we not use these drugs? In the third step, we will try to study the dosage, whether it is still therapeutic or either lethal already. The fourth step will be the mechanisms of action. How is this drug working? And the adverse reaction or the side effects is again another important consideration in our drug study. And finally, we will know what is our role as a nurse in administering drugs, either before giving it, during the administration, and even after administration of the drug. So take note, we will use this technique of drug study when we deal with the drugs. Let's talk about the indications or reasons for giving an antipsychotic medications. This medication is warranted to those clients who are suffering from the following conditions: the schizophrenia, suffering from psychosis, the bipolar disorder under the manic state, those patients who are suffering from Alzheimer's leading to psychosis, Huntington's and Tourette's, attention deficit hyperactivity disorder, and even the post-traumatic stress syndrome. All those mentioned indications are having what we can describe as the positive or a hard symptoms. That simply explains that positive symptoms are those patients suffering from hallucinations and delusions. And when we speak of hard symptoms, they are the impairment in the basic motor, sensory, and reflex behavior. In contrary, the negative or the soft symptoms are those patients who are suffering from depression or depressive state, an anxiety, a mood disorder of a manic depressive, and even the patient with post-traumatic stress disorder and patients having epilepsy. In classifying the client under psychotic condition, we shall be able to identify the positive or hard symptoms versus the negative or soft symptoms. Having mentioned of the indication called the positive or the hard symptoms, let's focus into a more meaningful illustration of the positive or the hard symptoms. While it is true that hallucinations and delusions are the foremost feature of a positive and hard symptoms, let's take a look into some other description. What you're seeing right now on the left at the right are pictures or clips of those patients who are illustrating a positive or a hard symptoms classified as combative or aggressive. So this kind of patient, there are some particular type of medications that shall be given. Next to that are those clients who are having a positive or hard symptoms classified under the thought disorders. At the left and at the right middle, they are indeed having a thought disorders. Next to that would be the picture at the right upper and the left lower. These clients are having a positive or hard symptoms that are further described as manic and hyperactive. This is of motor and reflex behavior. Added to that would be a client who are suffering from a positive or hard symptoms described to be having an odd or bizarre behavior. At the right, lower, and at second, middle, left. So these are all what we describe, what we illustrate to be a positive or a hard symptoms. Having mention of a negative or a soft symptoms as an indication of psychosis, let's take a look into a more closer definition of a negative or soft symptoms. At the pictures to your right and to your left are what we call the hallmark of a negative or soft symptoms called the severe depression. At this point, patient is losing motivation and there is a possibility of suicidal ideation if the patient's severe depression cannot be addressed. Added to a negative or soft symptoms are the apathy and a motivation, which the picture from the left lower and at the right middle are showing. One is the apathy, okay, and the second is the motivation. In the third illustration, these two clients at the upper right and upper left are exhibiting what we call the anhedonia and the alogia. These are both all classified as negative or soft symptoms compared with the positive or the hard symptoms. The drug name and classification. Antipsychotics were previously known as the neuroleptics. They are classified as to first, second, and third generation. As early as of 1950s, antipsychotics has already been introduced. And those medications that have been used from 1950s up to the 1970s are what we consider as the first generation antipsychotics. However, from then on, 1970s, it has been improved and they've been called as the second generation. And the third generations are those recently introduced. Neuroleptics or antipsychotics can also be classified as typical and atypical. Typical antipsychotics are conventional, or they are the old type. These typical medications are said to be very efficient for those hard or positive symptoms. However, the disadvantage would be it has a higher rate of extrapyramidal side effects. In our later discussion, we will give emphasis on what is this EPS all about. Typical antipsychotics also have a high affinity for dopaminergic receptor, DRD2. In our knowledge of neurobiology, together with the mechanisms of actions of the drugs, we will get to know what is the difference between typical and atypical with respect to dopaminergic receptor. Speaking of atypical, compared with atypical, if typical is conventional, then this atypical is unconventional, meaning this is a later date when manufactured. And it is said that atypical can be considered as efficient for both the positive and the negative symptoms. The great advantage of this atypical medication is that patients are giving positive feedback about these medications because it has a lower rate of extrapyramidal side effects, or all of the side effects are lesser compared with the typical medication. And like that of the typical, the atypical has a low affinity for dopaminergic receptor, and yet it has a high degree of occupancy for serotogenic receptor 5-HT2A. That means it is not only the dopamine as a neuroreceptors where atypical medications are affecting, but as well with the serotonin. This is other than the dopamine. At this point, I would like to draw your attention to the particulars of the antipsychotic drugs. I know at one point, the very first time you hear this, it wouldn't be that easy that it will appeal to your memory. There's indeed a lot of work for you to do, and this will entail memorization. However, at times it may be impossible to do that. That's why you have to imply familiarization of that things. And in doing so, there are techniques and strategies for us to easily remember all of these medications. Let's start. Now, the first approach is we have to classify what kind of an antipsychotic medication is that. Is it a first generation or is it a second generation? By the looks of it, it's hard to tell. However, when you have classified it already, you have to classify the first generation antipsychotic drugs into a high potency or a low potency. I want you to remember again, as from our previous discussion, okay, first generations antipsychotics are said to be the big guns. They are the drugs that do have a good effect or strong potency, that they will address the need for a hard and a positive symptoms. Whenever the patient is so aggressive, the patient is so combative, this is the first line of medication that is being given, and this comes in different name. The first technique would probably be best to classify the first generation as to the second generation. And after knowing the first generation, you have to further classify that into either a high potency or a low potency drug. Now, another technique that you may utilize in order to study well is by classifying the drugs according to the suffix or the endings of the drugs. Let's take, for instance, chlorphromazine, triflupromazine, thioridazine. All of these are ending with zine, and these are the drugs classified under phenothiazines, and these are classified as the first generation. Or either you may hear the word haloperidol, trifluperidol, everything that ends in dol and dol, these are butyrophenones, and these are still under the first generation. Like the atypical or the second generation, you may classify these drugs as to clozapine, olanzapine, quetiapine. Okay? And these are all classified as under the atypical. So you may, from the word or the way you hear it, you may appreciate it as to what classification of drugs as it ends with the suffix. So this is another approach in order for you to have an appreciation of what kind of a drugs are you dealing with. Now, the third approach is by having a chart which will exhibit the side effects of the drugs that you're working with. Under this category, you may see that there are extrapyramidal side effects, sedation, the anticholinergic effect, and the orthostatic effect, and other adverse effects. Now, if you will classify under the EPS, those drugs that has the higher affinity for EPS are those fluphenazine, the haloperidol haldol, and these are the drugs under the first generation. They do have a very high affinity for EPS, and that is not good. That's why most doctors are not using these drugs if only the patient is not having a hard symptoms or a positive symptoms. But look at the sedation effect of the drugs. Clozapine is an atypical drug. That means it is a second generation, yet it has a very high affinity for sedation. Together with anticholinergic effect, this clozapine is one of the strongest atypical drugs for psychosis or schizophrenia. This is one of the favorite drugs. And you may notice that with respect to sedation, anticholinergic effect, when we say anticholinergic effect, this mimics the sympathetic innervation. The patient will tend to have a dry mouth, constipation, urinary retention, dilated pupils, blurred vision, and so forth and so on. There's a lot of side effects by using clozapine. However, you may notice that the effects of the EPS is less when it comes to clozapine. This is another way on how you have to strategize on looking into the nature of the drugs, the classification of the drugs, the mechanisms of the drugs. Now, another learning strategy is by highlighting what are the most favorite drugs under question when it comes to board examination. And highlighted with the red color, these are the drugs that you must know. These are the must-know drugs. When I say must-know drugs, these are the drugs that you really have to know by heart, because all the nurses must know this. Let's take a look into the details of that must-know drugs. First, let's talk about the first generation haloperidol haldol. As I said, this is a high-potency, typical first-generation drugs. Now, when I say high-potency, these are big guns. Whenever the patient is combative, aggressive, this is the first line of medications that the doctors are giving. However, there are so many side effects, like the EPS, extrapyramidal side effect, like that of the tardive dyskinesia. And the worst of all with the effects of haloperidol haldol is the neuroleptic malignant syndrome. This is a matter of emergency. If you are a nurse and your patient is suffering from, after administering haloperidol haldol, your patient suffers from NMS, then that's an emergency situation. You really have to call the healthcare provider or the doctor. And patient will have a dystonia. This is a condition where the patient is having a muscle fatigue of the neck, the face, and the tongue. These are the negative side effects of haloperidol haldol. Now, next to that, another familiar drug is the Chlorophromacin Thorazine. This is another drug under typical or the first generation drugs, which has a low potency. However, these drugs can cause several problems, such as the orthostatic hypotension, skin discoloration, the photosensitivity, and corneal deposit. Now, fluphenazine or prolixin is also a high-potency first-generation drugs. Like of the haldol, it has a very high affinity to EPS, tardive dyskinesia, and neuroleptic malignant syndrome. Now, these are the typical antipsychotic drugs which are commonly being asked in the board question. Haldol, Thorazine, prolixin. So, one of the many days in your college life, once you are taking psychiatric health nursing, your friends may tease you out for a joke taking all of this medication, and that will in any way, in anyhow, will help you remember all these drugs. Now let's take a look into the atypical antipsychotic drugs. One of the most favorite question here is the clozapine. Clozapine, as I am saying, is a drug under second generation, atypical. As you may see here, clozapine is the generic name and the trade name is Clozaril. You may see here that there is binoculars, clozapine, close, aiding your memory with close. You have to close watch sleep for the patient when you are giving clozapine. Why? For this reason, there's a possibility that the client may suffer from a granulocytosis. And a granulocytosis, of course, is also known as the neutropenia or leukopenia, where there is a decreased neutrophils. There's a decreased WBC and decreased immune system. And you always have to watch out for whether your dosage is getting high. And you always have to order for the blood exam. Now, under clozapine, Clozaril, you have to take note also that this can cause a decreased metabolic syndrome. This can cause weight gain. The patient is almost always sedated. And the good thing about clozapine, Clozaril is that this is the only drug that can lessen the suicidal tendency among all the drugs. Other than that, the risperidone, Risperdal is also one of the favorite drugs in the board examinations. You have to take note that this kind of drugs can cause the following. It can cause a prolonged QT intervals. It's a cardiac effects. It can also cause weight gain, hypersalivation, and increase extrapyramidal side effects. And one of the most common in Risperdal, Risperdal is that there is hyperprolactinemia, which can cause even for a male to suffer from gynecomastia. Okay? Now, another atypical drugs that is of importance is the Olanzapine Cyprexa. Now, if you may notice, Olanzapine starts with letter O, and that is, you see here the big guy with the big tummy. This can cause an increased rate of metabolic effect. This can cause fever, rash, and swollen lymph nodes. Now, having said all of these techniques on how you will deal with drug study, I wish you well that you may find joy while you are studying antipsychotic medication. The mechanisms of action of antipsychotic drugs. This will answer the question of how does the antipsychotic works. The antipsychotic drugs, or the neuroleptics, are known to be the antagonist of a dopamine D2 receptor. When I say antagonist, meaning they block that dopamine inside the brain. I want you to take a look at this. This is a synapse, and what you're seeing are flow or excessive flow of dopamine coming from a terminal presynaptic ending of axon to a postsynaptic dendritic area where there are receptors. There's an excessive flow of dopamine here. And that causes psychosis. Now, I want you to take a look at the PET examination, or the positron emission tomography scan. If you will see at the left lateral side of the brain, there are red markings here that indicates hyperactivity caused by the dopamine excessive secretion. As you may look at it, it's like fire burning your brain. Another is a view from an anterior position of the brain of the PET scan. You will see here that there are isolated, it's like a bushfire scattered in your brain. And another from a ventral view of the PET scan, you will see here again, there are traces of dopamine oversecretion. And that makes a person become insane that makes a person become psychotic, either a manic or either a depressive state. Now, let's take a look at this situation where that red particles are said to be from either a drugs of cocaine, heroin, methamphetamines, alcohol. This causes hyperstimulation of the D2 receptors of the nerves. And this causes addiction. This causes, sooner than later, an abuse of all these drugs can cause to psychosis, because there will be an excessive release of dopamine. And the action of the antipsychotic drugs is to block that receptors. The antipsychotic drugs will block that receptors in order for the dopamine not to transmit the signal to another neurons. And that includes the clozapine, the atypical and the atypical drugs to work on with this problem of psychosis. So we may therefore say that the culprit for psychosis is no other than the dopamine. When you have an excessive dopamine, you are more apt to suffer from psychosis. And when you have less dopamine, you are going to suffer from attention deficit hyperactivity disorder, or either you may suffer from tremors. These are the extremes of high and lows of the dopamine. Now, the next question here is, where is this dopamine coming from in our brain? What part of the brain, and how does it affect our brain? And that's what we will talk in the next slide. This discussion is still under the mechanisms of action of the antipsychotic drugs in relation to the dopamine. Let's try to get to know more about dopamine. Now, what you're seeing right now is a sagittal view or a sagittal section of the brain. And to the question of where does the dopamine originates, here are the locations on the origin of dopamine. And they are originating from a dopaminergic neurons. Meaning there are neurons in that part of the brain that is capable of synthesizing all those dopamine as a neurotransmitter, and that are concentrated in the midbrain in this area, where the substantia nigra and the ventral tegmental area are located in the midbrain. Other than that, there are some other locations where dopaminergic neurons are located, such as that in the hypothalamus and in the prefrontal cortex. Now, other than that, there are what we call the dopaminergic pathways. Once the dopamine are being synthesized here, there is a need for that dopamine to be delivered, to be transferred, to be carried on to the different parts of the brain. And this will travel through what we call the dopaminergic pathways. And this includes what we call, one, the mesocortical pathway, which is highlighted by a yellow color. As you may see, from the midbrain, the dopamine will travel to the different cortical area. And that dopamine will be scattered there. Other than that, the Mesolimbic Pathway, as indicated by the colored blue area, from the midbrain going to that area of the hypothalamus. Now, this mesocortical and this mesolimbic area, okay, will now receive the dopamine. It will be delivered to the nucleus accumbens, to the amygdala and hippocampus, and some other prefrontal area. The dopamines will be delivered, scattered at that area. And whenever these pathways are innervated, this will be responsible for your memory. That's why you remember those pleasurable moments. You will have your motivation and emotional response. That is to your reward and desire. That's why you keep on loving to eat, to drink, to socialize with friends, to hang out, to chill out with your friends, and even some other pleasurable things like that of sexual drive. These mesocortical and the mesolimbic pathways will also cause addiction. However, on the negative sides, contrary to that, this mesolimbic and mesocortical area, when in trouble, can cause hallucination, delusion, and schizophrenia if they are not functioning well and properly. Now, other than the mesocortical and the mesolimbic pathways, we have what we call the Negro striatal pathway. The Negro striatal pathway is highlighted by orange color. And this is the Negro striatal pathway. This is responsible for the motor control. And if the neurons here will die, this pathway can result to Parkinson's disease. And that's why some medications, particularly the typical medications, are having a very high affinity to extrapyramidal side effects, and the DRD2 pathways or the receptors. Finally, we have what we call the Tubero-Infundibular pathways, and this is responsible for hormonal regulation. This is responsible for maternal behavior, pregnancy, and sensory perception. This is highlighted by a red color indicator line here. Now, having mentioned all of this, having known where does the dopamine originates and how does it travel, we now have a broad knowledge on what is this dopamine all about and how does it causes problem and how does the antipsychotic medication works by blocking that dopamine. And this is all about the mechanisms of action in relation to dopamine.